doing a phenomenal job, and nice to see so many young people and parents who I haven't seen for a long time. So I've been asked to talk a bit about pituitary services in children, and pituitary disease in children is very rare actually, and so seeing it from a surgical perspective, there's many questions which come up, and I'll try to address some of them today. So pituitary disease is complex, as we saw. It affects many other organs and many effects on children. They're very rare, and most of them are actually managed medically, so they don't need surgeons all the time. And there's a significant consequence if they're not treated. There's metabolic effects, neurological effects, reproductive and even psychiatric effects. And there's potentially very serious surgical adverse events as well, acute and chronic. So there's a big distinction between pituitary tumors in adults, which are relatively, I should say, common within the brain tumor world in adults. They're usually large tumors. They're usually non-functioning adenomas, benign but large and non-functioning, as opposed to children, where most of the tumors actually are functioning tumors, so they produce hormones of their own accord. They're also benign tumors. The majority of pituitary tumors in children are prolactinomas, which produce prolactin. And those, thankfully, there is a medical treatment for that. They're given cabergoline usually, which is a drug that suppresses prolactin production. And that is usually managed entirely by endocrinologists. The other ones here are more surgically oriented, mostly Cushing's disease. Any pituitary tumor that causes visual compromise often needs surgical removal, otherwise the vision may not come back. And there are some prolactinomas where surgery is needed because either the drug hasn't worked, and they're very rare, or because the drug is poorly tolerated. Cabergoline does have some psychiatric symptoms, and we've had patients who needed surgery for their prolactinoma simply because they couldn't tolerate the drug. But probably the commonest surgical pituitary tumors in children are Cushing's disease, and I just wanted to spend a few minutes on this because it's important, I think. So Cushing's disease is a disease where there is too much cortisol in the brain because there's a small tumor in the pituitary gland that's producing too much, what we call ACTH, which then drives the adrenals to produce too much cortisol. And in small quantities, cortisol is really important. It keeps us alive, allows us to deal with stress. But if you have too much of it, it can be dangerous. They are benign tumors like other pituitary tumors, and they're often very small, so very different from the adult situation where you have large tumors, often causing vision problems. These are small tumors, some of them not even visible on an MRI scan, which again introduces another level of difficulty. And this is what hypercortisolism, too much cortisol, causes. So you get personality changes, you get high glucose, you get hypertension, you get sodium fluid retention, you get a myopathy, which is a weakening of the muscles in your arms and legs, and some people can't walk, in fact, because they have so much chronic hypercortisolism. And the other thing is, of course, they become obese. You get a type of obesity related to the hypercortisolism, which is very difficult to reduce over time. They also get bone weakness with osteoporosis and fractures. They get thin skin with stria, and also these very frequent bruises and petechia. But in children, they don't just get that, they also get growth failure. So children with Cushing's disease typically stop growing. And that can be obviously a very serious thing, because if you don't treat your Cushing's in time, then even giving them growth hormone may not be enough to make them grow enough to reach their expected height. So I just wanted to very quickly go through two brief cases. This is one girl who is now 14 years old. At the age of 10, she began developing weight gain. Her body shape started to change. There was severe anxiety and also a bit of depression. She had primary amenorrhea, delayed puberty. Her MRI scan was normal. And it took 2 years for investigations for Cushing's to begin. She was started on metyrapone, which is a drug which suppresses cortisol production. And by the time she got to us, had been through 3 hospitals and 3 different teams. She got to have successful transphenoidal surgery in January 2025 and is now significantly better. And there's a second child, an 11-year-old girl. Again, 2 years before then, she developed progressive changes in body shape, began to gain weight, stopped growing, and despite making huge efforts to lose weight, doing a lot of exercise, she never managed that. And this is, for an 11-year-old girl, this is very important. They're body shape is changing in a way which is beyond their control. And at that time in their life, this is crucial. They start withdrawing from social activities, they hate school, and it has a huge effect on their life. Again, she had been to 3 hospitals and teams. The MRI scan showed a very small microadenoma, very small tumor in the pituitary gland. And eventually she came for transpheroidal surgery and had that in February this year. We looked at our series of Cushing's patients recently, at 25 children treated at Gosh over about 15 years. Many of them were females, and it's that age where most young people are growing, and it clearly interferes with their puberty, their development, and their perception of who they are and their identity. These are the symptoms they get. So weight gain is the commonest. Cushingoid face with acne and a big, a face swelling, essentially. They get growth failure, headaches, hypertension, and look at the symptom duration. The average was 2.1 years. So it took these children just over 2 years for somebody to notice that this could be hypercortisolism. And the adenomas, these are just some scans here, but you can see that the adenomas, the tumor is actually quite small. This is the whole pituitary gland. The adenoma that's producing the high cortisol is just a tiny little thing over there, which is even hard to find at surgery and hard to see unless you have a specialist radiologist with an interest in this. And this is just about bilateral petrosis sinus sampling. This introduces another level of difficulty in diagnosing these patients, because this is essentially an angiogram done through the veins, where an interventional radiologist passes a catheter all the way up into the jugular vein to the petrosis sinus, which is at the bottom of the skull, at the skull base. And it's important to measure the cortisol level at that point in the body, because if you do and it's high, then that defines that the cortisol is actually coming from the pituitary gland. There's other things which can cause high cortisol, and you don't really want to go and explore a child's pituitary gland if you're not sure that the cortisol is coming from there. So this is crucial. And this is, in fact, is still something we cannot do at Great Ormond Street. It's only done in Royal Free and a few hospitals in the country, and it introduces a certain level of difficulty for these patients. It's sort of angiogram you want to do. So, it is only a few people in the country can do this. So in our series, they all had transpheroidal surgery, some microscopic, some endoscopic. That doesn't really make a big difference. And we managed to cure 76% of them, which is in line with the literature, really. We had persistent hypercortisolism in 6. So almost a quarter of them did not actually get cured by the first operation. But of those 6, another 3 had a second operation and then were cured successfully. Notice that even in a small number of patients, you still get complications. So diabetes insipidus is an important complication. Thankfully, it was transient, so they didn't need to have any long-term hormone replacement. And also, because you're going through the nose, there's a risk of a leak of fluid, of CSF, of brain fluid from the nose, which can cause infection and meningitis, and that can be very serious. And that happened in 3 of our patients, and it settled with lumbar drainage and a bit of time. So this is our pathway at Great Ormond Street. So we first reviewed them in our neurosurgery clinic in Great Ormond Street, so a pediatric neurosurgery clinic. Then they're often discussed in 2 fora, in the HPAT, which of course Helen had pioneered about 10 years ago now, and also at the Queen's Square Pituitary Multidisciplinary Meeting. We then complete the investigations, make sure we have everything, and they have surgery at Great Ormond Street with an adult pituitary surgeon. And then they have follow-up through surgery and endocrinology. So the key issues are a delay in recognition and referral, both at the primary level, sometimes even at the pediatrician level. So they take a long time to come to a pediatric endocrinologist. The patient age is key, because these are children, as we said before, who are developing at the pubertal stage of life. The symptoms can be very severe. They have growth failure, and they have a significant psychosocial impact. And from a surgical perspective, there are a couple of challenges. This is a typical adult pituitary tumor. You can see it's large compared to this tiny one here in a Cushing's child. And the other thing you can see as well is the sphenoid sinus. So when you're going to do an operation through the nose, it's a transsphenoidal operation. In an adult, the sphenoid sinus is always aerated. It's got air in it, so you can find it easily. And you can go through that and open the floor of the pituitary cella. Whereas in a child, you often have bone, because it takes about 12 years for the sphenoid sinus to develop air in it. And so very often you have to drill through the sphenoid sinus, which increases the level of difficulty. And you're only doing it through a small window. It's barely a centimeter wide. So you can see a sphenoid sinus in a child typically is just bone. In an adult, it's full of air, and that does make a difference. So you may have heard of GIRFT, get it right first time. In the neurosurgical world, the first time we heard of this was through the spinal services. But then it became very clear that GIRFT is challenging, and to get it right first time requires a whole collaborative effort. And perhaps it's more important in those specialties where the volume is small and the number of surgeons doing the procedure is also small. And this was one of the first GIRFT reports from 2018, which shows the number of surgeons doing transsphenoidal procedures for pituitary tumors in the UK and Ireland. And this is, of course, is adult numbers. The pediatric numbers are tiny, but these are adult surgeons doing transsphenoidal surgery for pituitary tumors. And you can see that there are a few surgeons doing large numbers of transsphenoidal procedures every year, but there's also many doing very small numbers, and that is potentially a worry. So even in adults, pituitary tumors represent a low volume service. And in this period of time, so up to 5 years ago, there were 18 surgeons in the country who did more than 100 procedures, but 45 surgeons only did one procedure. And that is a little worrying, isn't it? And this has an impact on the multidisciplinary team. If you're one transsphenoidal surgeon doing a very small number of cases in one unit, then your neuroradiologist and your endocrinologist are hardly likely to have the experience to develop your service better. And there's a recent paper, February 25, in fact, from the British Journal of Neurosurgery, showing some results depending on volume. And they look at 4,500 transsphenoidal procedures, and they found that higher surgeon volume is associated with a reduced risk of repeat surgery, with a reduced risk of post-procedural hemorrhage, it's a bleed in the pituitary gland after the surgery, and the length of stay. And you can see if you plot length of stay against the number of cases that a surgeon has done in the previous 12 months, your lower surgeon volume is going to be associated with a much higher length of stay in hospital than if you have a high volume surgeon. And there's another interesting study from a couple of years ago trying to define what a pituitary center of excellence is. And this is a group of 9 large pituitary centers worldwide, including places like Boston, Brazil. There's one center from Rio, has very huge numbers. They reviewed activity over these 2 years. The activity was reviewed blindly, and they tried to look at the median values, what does make a real center of excellence for pituitary tumors, and what is the low acceptable limit. And you can see here that the number of pituitary interventions, the number of surgical interventions varies between even high-level units, but there's about 100 as a median. The number of surgical interventions per year, depending on the number of surgeons doing them, is also variable. But also note that there's a number of trained nurses here that was looked at in this study, and that's also important. We're very lucky at Great Ormond Street, thanks to Helen and others, to have at least 2 pituitary nurses who do a lot of work for our patients. And this study essentially concluded that acceptable criteria are that you have at least 1 to 3 dedicated pituitary neurosurgeons in the unit. You need to do at least 50 to 100 procedures per year, and you should have a readmission unit, a readmission rate of less than 10%. And then with respect to the other specialties involved, you should have at least 4 endocrinologists, 2 radiotherapists, and dedicated neuroradiology, pathology, and ophthalmology. So to go back to children now, do we agree that pituitary services for children are accessible or not? I think they probably are accessible, but are they simple? Are they navigatable? And do families and GPs and maybe, should I say, pediatricians understand them? So because this is a success conference and we need to have clear answers and clear plans, what do we need? And I think these are all important things we need for pituitary services in children. We need established clinical pathways. We need to educate primary and secondary care. We need peer review and discussion of individual cases in the appropriate fora. We need expert surgery. As pediatric neurosurgeons, we need to collaborate long-term with stable collaborations with high-volume pituitary surgeons, not with somebody who does 1 or 2 a year, but with somebody who does a lot of cases. We need to collate data and bring out outcomes and develop an understanding of what our adverse events and complication rates are. We need to understand the long-term effects. And when necessary, this does happen even for pituitary tumors, they may need rehabilitation. So and of course, it's important to remember that this is just a tip of an iceberg. There's many other tumors like craniopharyngiomas. We often talk about craniopharyngiomas here. They're not very different. They're probably a bit commoner than pituitary tumors, and they require more surgery than pituitary tumors. But they are in the same bracket. We need to have experienced surgeons to be able to do them safely and effectively. And very lucky in Great Ormond Street to work with a good team of people who are very committed and dedicated. And thank you very much.